So it's my pleasure to introduce our next speaker, Matthieu LeGrand, who is a professor of anesthesia at UCSF. Welcome, Matthieu.
Thank you so much, dear Chairman. Dr. Mehta, thank you so much for the invitation. Always a true pleasure to be here. So today I talk about sepsis-associated acute kidney injury and what have we learned so far. Here are my disclosures. So I'll give you an example. You might disagree, but there's a kind of HIP and progress note we can see in a patient being admitted in the ICU. See, patient 73 years old, admitted to the ICU for community-acquired pneumonia and respiratory distress complicated by septic shock with AKI due to acute tuberous necrosis in the setting of hypertension. I'll try to discuss in the next few minutes that why this might be at least partially inaccurate or at least miss some important information in the description of AKI in a patient with sepsis. So, of course, that we have learned much more than that, but for the time, I pick up what I thought that would be maybe an important aspect to discuss. And the three aspects I wanted to discuss today is first, we know that sepsis-associated AKI has an attributable mortality in our patient with AKI. In patient with sepsis or septic shock, developing AKI leads to higher mortality. We know that also sepsis-associated AKI shows sign of tubular injury, but actually little necrosis. And we'll see that hypertension, as we saw in the note, is far from being probably the main reason why patients develop sepsis-associated AKI. And then sub-endotypes exist and are associated with worse outcome and maybe different responses to treatment. We'll see that. So attributable mortality are many papers associating AKI and mortality in critically ill patients, including sepsis. And here in this study, actually with Dr. Liu here, we re-examined all the NIH-funded trials looking at ARDS and including ARDS due to sepsis, and you might know that sepsis and pneumonia is a leading cause of ARDS in our patient over the last 30 years. So first thing you see that the incidence of AKI and severe AKI, and as you can see, actually the incidence when we look at data from ARDS patient, slightly different inclusion criteria, but overall ARDS patient, the incidence haven't declined and maybe actually increased or has increased over time. And then we look at attributable mortality. I'm sorry, it's a bit blurry. We use machine learning to try to attribute the mortality to AKI, all those things being similar. Otherwise, what's the difference of mortality in a similar patient who developed AKI versus a similar patient who did not develop AKI? And here you see, I'm very sorry for the quality. Here is AKI, severe AKI, and here it's through the different trials we look into, and you can see that AKI was at an attributable mortality of about 50%. And when we look at acute kidney disease or acute kidney injury, which didn't resolve rapidly, the attributable mortality was around 30%. Meaning that for the same patient, having AKI and especially acute kidney disease increase your risk of dying by almost 30% in those trials. Then second point, that sepsis-associated AKI shows tubular injury and little necrosis. This one of a study looking at biopsies of patients dying from sepsis and control patients dying from other critical illness. And what the authors show that actually tubular injury was very common, presents focally, but most renal tubular cells appear normal with very little sign of necrosis. Electron microscopy revealed increased tubular injury in sepsis, including atopic mitochondria, and so mitochondrial injury, and increased autophagosomes in those patients. And you see here the percentage of tubular injury compared to controls in sepsis. And actually, we know from different investigators, the authors, that in many, at least preclinical setting of AKI, renal blood flow is not impaired or not severely impaired. I mean, many works from Rinaldo Bellomo's group and others, and here I'm showing only one example, and one of the reasons is probably at least the dysregulation of the renin-angiotensin system. And in patients with AKI, we can see a decrease of GFR, glomerular filtration rate, despite seeing an increase or stable renal blood flow, and probably at least partially due to the dysregulation of the vasoconstrictive effect of angiotensin 2 on the efferent arterioles, decreasing the hydrostatic pressure in the glomeruli. And that's very nice work from Dan Leishman a few years ago in animal model, showing that actually in animal model with sepsis, the renal blood flow increased during the sepsis challenge, and administration of Ang2. Exogenous Ang2 return the renal blood flow to normal value and increase the GFR, the renal functions. So we know that tubular injury is common, that decreased GFR is common, but also we know that we miss a lot of patients with a decreased GFR and some degree of sepsis-associated AKI in our patient, and only looking at serum creatinine can be misleading. The reason that you see this relationship before is that creatinine takes time to increase, despite the GFR could be being impacted earlier on. And among others, also we looked at the impact as the association between positive biomarkers of acute kidney injury or decreased glomerular filtration. Here we use pancreas, proenkephalin, and showing that in patients with sepsis-associated AKI, elevated biomarkers of acute kidney injury, here pancreas, even in patients with, I would say, not normal, but not high creatinine value, were associated with worse outcome. So patient not meeting the criteria for acute kidney injury, but elevated biomarker of acute kidney injury had a higher risk of dying, in that it was in adrenal studies of patients with sepsis, patients in frog ICU, in the frog ICU cohort, including mostly patients with sepsis. And I'll finish with, and maybe most importantly, that subphenotypes of sepsis-associated AKI exist. And I think that has been a major interest over recent years in critical illness, including ARDS, sepsis. But actually, probably our goal in the future will be to identify subphenotypes and ideally even some endotypes of critical illness, including critical ill patient with sepsis and with an AKI. And ideally, of course, the goal of identifying these endotypes will be to identify treatable treats that will allow to target a pathway that will improve our patient's outcome. That's probably the landmark study in sepsis-associated AKI, or in AKI in critical illness, but a lot of those patients were sepsis-associated AKI from Pavan Bhattacharjee. What Pavan did is he took two critical ill population, a discovery cohort and a replication cohort, and apply a clustering technique. It was a latent class analysis to identify subphenotypes of patients with a critical illness and AKI. And then he applies this subphenotype and clusters to a subset of the VAST trial, vasopressin and septic shock trial, to look at potential different response to treatments, potential heterogeneity of treatment effect. And actually, the group identified clearly two subphenotypes of patients with sepsis. Here, it was phenotype 1 and 2. Here in red, with biomarkers or variables overexpressed, overrepresented in the cluster. In blue, underrepresented or underexpressed. And you see biomarkers of vascular or vascular regulation, H2, H1 regulation, biomarkers of inflammation, biomarker of endothelial injury, biomarker of inflammation, and of course some variables associated with the outcomes. And what the author found that those patients actually had very once again, sorry for the had very different outcome. In the cluster 2, you see that mortality in one cohort was 25% versus 6% in cluster 1, 38 or 36% versus 13% in the replication cohort. So very different mortality and very different response to treatment. Actually, looking at the VAST trial, only patient in phenotype 1, so actually the less severe patients, showed decreased mortality when treated in the vasopressin arm compared to the control arm, versus no difference in outcome in mortality when patients were treated with vasopressin in a subphenotype or cluster number 2. So heterogeneity of treatment effect. Here, I wanted to share with you preliminary data. Please do not share. We have on sepsis-associated AKI and endotypes. And I wanted to share with you because I'm very excited about those results. Are not all in there, but I thought it was a good time to start sharing with you. We look at two different cohorts of critically ill septic patient adrenal study, 24 centers in patient associated in patient admitted with sepsis, including 319 patients with sepsis-associated AKI defined as the KDIGO criteria. Early study, Kathleen is one of the PI here from UCSF, 169 patients with sepsis-associated AKI, and we measure 366 biomarkers using proteomic profile with the O-link with three different big domains: cardiovascular, inflammation and immune response, and cellular metabolism. And in those two cohorts, adrenals and early, we identified two very similar clusters with, you see here, the correlation between cluster driving, between biomarkers driving the cluster, the two cohorts highly correlated. The two clusters were very reproducible in the two cohorts from two different continents. And cluster 1, you see, was associated with half of the mortality of cluster 2. Half of the mortality from cluster 2, both in the adrenal cohort, 30 versus 60, 31 versus 68%, and early 38 versus 61%. That's what I just showed. Looking at what's driving these clusters, you see, once again, I'm sorry, I don't know why it's so blurry. Looking at pathway analysis, what were the highest number of biomarkers driving these clusters and how they and how they function as a pathway. You see that in this cluster, a lot of the pathways were related to inflammation. Might not be surprising, but still very heavily affecting those clusters with leukocyte migration, chemostasis, regulation of T cells proliferation. One of them, again, leukocyte chemostasis and TNF, IL-17, and other regulation of the inflammatory pathways. So back to my HAP note. Maybe in the future, hopefully in the near future, we won't write or see AKI due to acute renal necrosis in the setting of hypertension, but rather something like maybe this patient present with a type 2 sepsis-associated AKI, and maybe we could dream of this patient might be a candidate for example, anti-inflammatory drug number 1, 2, and more personalized medicine for patient admitted in the MICU for sepsis and sepsis-associated AKI. Take-home messages: we know that AKI in the setting of sepsis have attributed mortality, so we can expect and hope to decrease the rate of AKI and mortality at the same time. we have a sign of tubular injury, but little necrosis, but subendotypes seem to exist and are associated with outcome, and seems to be especially driven by inflammation, leukocyte migration, and adhesion. Thank you for your attention.
Thank you very much, Matthieu. Are there questions? I was wondering when I saw your endotyping slides with all the complex inflammatory mediators that you do they also relate to clinical phenotypes? Sepsis associated AKI, we think is a homogeneous group, but in fact this is not true, of course. They have a history of cardiovascular disease or congestive heart failure. They have they are administered nephrotoxins, etc., etc. So there's many factors playing a role. Could you tease that out also?
Yeah, no, certainly there are differences in the patient characteristic between the sub-endotypes, but with a large overlap. That means at the individual level would be very complicated. For example, the history of diabetes or even being on a slightly higher dose of vasopressor will be very poorly predictable of belonging to one endotype versus another. There might be some differences, but they're poorly accurate in predicting to belong to one endotype versus another. That's been shown also in IRDS patients. We know there are some differences, but very poorly accurately predicts belonging to one versus the other.
So we need to progress with these advanced endotypes. Nice. Okay, thank you very much.
Thank you so much.